Welcome to The Explainer. Today, we're unpacking a really fascinating, honestly, deeply important concept from the Vibrons course titled Clinical Cognition from First Principles. I am so excited to guide you through this because this material aims to do something completely revolutionary. It literally illuminates how medical reasoning actually moves. We aren't just looking at the final diagnosis today, we're looking at the actual engine of thought that gets a clinician there in the first place.
So, think about the last time you or a loved one received a medical diagnosis. You likely heard the final answer, right? But how did the clinician actually arrive there? Studies show we often lose the why behind a diagnosis the minute the patient leaves the room. That internal thought process is usually a total mystery, just this invisible engine working behind the scenes. Well, in this explainer, we're going to trace that exact path. We're looking at the tools and frameworks that pull a clinician's internal reasoning completely out of the dark and into the light. Okay, let's dive into this outline, our zoom in, zoom out journey. We've got the invisible engine, building the core loop, the patient advocacy track, systems and scale, and finally, mastery and evidence. Section 1. The invisible engine, revealing the hidden path, which is lesson 1. The fundamental problem in medicine is that a clinician's reasoning almost always stays invisible. I mean, a clinician takes in raw data, thinks about it, and then just outputs a conclusion. But what if another doctor, or even a patient, wants to know exactly why certain possibilities were discarded and others were kept? That path is often totally lost. To fix this, we need the clinical cognition trace. That's visualizing the actual path taken from raw findings to a final conclusion. But how do you force this invisible trace into the open? Well, the course introduces this brilliant mechanism, AI-driven Socratic questioning. Instead of an AI that just hands you an answer, this system questions the learner. It forces a genuine attempt at reasoning before revealing the answer. By demanding that the clinician articulate their thought process step by step, the Socratic loop captures what they actually retain and how they actually think. Section 2. Building the core loop, stress testing the differential, covering lessons 2 through 4. So once that trace is forced into the open, it needs to be refined. Lesson 3 structures this process so perfectly. It absolutely doesn't allow a leap straight to the answer. First, we start with step 1, the raw findings. Then, step 2 is probability weighting, meaning the clinician must actively assign weight and likelihood to different potential diagnoses based on the evidence. Finally, step 3 is a mandatory self-critique. The clinician literally turns the discipline inward on their own reasoning. Like, did they favor one diagnosis just because they saw a similar case yesterday? Actually, that's called anchoring bias. This step molds raw instinct into a highly rigorous, stress-tested differential. Of course, human cognition is flawed, which is why Lesson 4 focuses entirely on bias and failure modes. The course audits the reasoning by looking at 5 distinct angles of failure. Notice the moment of commitment. That exact second, a clinician decides what the diagnosis is and just stops looking for alternatives. Or the load-bearing finding. Like, what if the entire diagnosis of anxiety hinges on a high heart rate that was actually caused by an underlying infection? By auditing signal versus noise and looking at distortions during patient handoffs, the reasoning is vigorously checked before it ever gets anywhere near the patient. All right, Section 3, Deep Dive Patient Advocacy Track, the pivot point of communication, which is Lesson 5. Now, what's really interesting about this is that this is the absolute pivot point of our explainer today. This is our core focus. Up until now, the course has focused entirely on the clinician's internal brain space. But medicine is a team sport, right? And the most important players on that team are the patients and their advocates. Look at the contrast here. You have the original clinician's trace, internal, invisible to outsiders, focused on arriving at a single diagnosis. But then we see the evolution into the translated trace. This is where reasoning becomes a structured, longitudinal record meant to be relayed onward. It's no longer just for the clinician who produced it. It's explicitly designed for the people who have to act on it next. It's a total game changer. To really grasp this, think about a flight data recorder, but for medical decisions. If something goes wrong, or honestly, even if you just need to hand a patient over to a new specialist, you don't just want the final destination. You want the black box. You want a structured, longitudinal state log that says exactly what data was present at 10 a.m., what the clinician thought about it at 11 a.m., and why they chose treatment A over treatment B. This level of extreme transparency is exactly what Lesson 5 is building. Let's break down the specific modules that make up this crucial patient advocacy track, because this is where the magic happens. Modules M2 and M3 are tasked with capturing the initial reasoning state, locking in that flight data right at the beginning. Then M11 takes that raw logic and structures the trace for external review, formatting it so a completely fresh set of eyes can easily audit the thought process.
And finally, M13 is the ultimate translation layer. It translates the clinical logic specifically for patient advocates and caregivers. This isn't just data processing, guys. It's about giving families a literal map of their loved one's care. It ensures that the family at the bedside isn't just handed a bunch of confusing medical jargon. They're handed a clear, translated map of the reasoning that led to their care plan. It is a profoundly empowering shift.
Section 4, Systems, Safety, and Scaling, taking the translated trace further, covering lessons 6 through 12. Let's move to and see how this builds. So let's see what happens when we take that translated trace and zoom way out to the macro level. In lessons 6 through 12, the course explores applying this visible reasoning to wider healthcare systems, hospital safety protocols, and large-scale scaling. Lesson 6 draws a really sharp distinction here. You've got single record reasoning, that intense focus on one patient, but then we scale up to registry-level population reasoning. This is where the disciplines genuinely diverge. I mean, analyzing the cognitive trace of 1,000 doctors across 10,000 patients requires a completely different analytical approach than just treating the individual sitting right in front of you. As we scale this core loop up, the course borrows heavily from other high-stakes industries, which is super cool. For example, for safety and systems, it takes FMMA, that's failure mode and effects analysis, a concept taken straight from engineering, and it applies it to clinical processes rather than single decisions. It also looks at healthcare ops, creating multi-agent distributed differentials. So instead of one doctor trying to figure the whole thing out, the reasoning trace is distributed and built across a whole team of specialists handing off information seamlessly. It even extends into precision medicine, giving us actual frameworks for resolving conflicting evidence and weighing patient preferences when the data just isn't perfectly clear.
Section 5, Mastery and Evidence, Clinical Wisdom and EBM, covering Lesson 13.
This incredible journey culminates in how we capture tacit knowledge. Lesson 13 tackles the pinnacle of a medical professional's career, clinical wisdom. How do you tell the difference between real, hard-earned expertise and, a dangerous shortcut that just kind of looks like expertise? The answer lies in periodically auditing your own compressed intuition. So the crucial point is how this all ties into evidence-based medicine, or EBM. The source material beautifully describes these as two sides of the very same coin. EBM asks the question, can I trust this evidence? But clinical cognition asks, how did I get from those findings to a judgment in the first place? These are complementary disciplines, not sequential ones. You could have the best evidence in the world, but if your cognitive engine is flawed, the diagnosis will be wrong every time. Which leaves us with this final, truly profound thought to consider. If evidence-based medicine ensures that we can trust the evidence, can we as a healthcare system accurately trace the judgment that acts upon it? The Vibrons course strongly suggests that making this invisible trace visible is not just a neat learning tool, it's an absolute necessity for the future of patient care and advocacy. Thank you so much for joining me on this explainer, and I really hope this changes the way you think about the invisible engines of human reasoning.